Hi friends, good evening. And I am Dr. Ashutosh Gupta. So today we are going to talk about the beta hCG levels. Okay, so we usually follow these beta hCG levels. Beta hCG is a very good hormone. We are always looking around for this beta hCG levels because then it brings joy and brings happiness to us. So probably it is a confirmation of the pregnancy. But what if the beta hCG levels are very high, that is in the tune of 2 lakhs? Then what? So meaning thereby that if we have conceived spontaneously and then we've done the serum beta hCG and then it is very high to the tune of something around 2 lakhs and 22,000, right? Then what to do? And is this something to get worried of? How do we manage, right? So there are two parts to it. One is the theory and second is the practical. So let us first understand the theory about it. So whenever we identify that the beta hCG levels are very high, so we do have those nomograms. I'll show you the graph. So we do have those nomograms in which we identify that what are the levels according to the gestational age, what it should have been, right? And once we identify that it is an high, so what could be the possible etiologies? So the etiologies is this, that probably we would have conceived as twins or multiple pregnancies, right? We can have a complete herediform mole, meaning thereby that probably the baby is not there and then the uterus is all filled up with this complete herediform mole. What if the pregnancy is there? So even though we identify that this is a singleton pregnancy and not twins, so what more information that I probably would need to know before I proceed further, right? So this could be a partial mole in the placenta with coexisting fetus, or probably I could have conceived as a diamniotic dichorionic as a twin pregnancy, and then one baby is good, and the placenta to that fetus is also good. The second fetus had gone into a vanishing, but then the placenta survived, and therefore we are having some sort of a partial mole changes, and therefore that would be responsible for the this hyper beta hCG levels, right? So let us see these cases, and then we'll discuss how do we manage. So this is the graph. So try to look around in here. So anything which is greater than 2 lakhs is definitely higher, right? So this is how what we can have is a complete for mole and a partial mole, right? So partial moles can be of two types, diandric and digynec, right? So it has to do something with the placenta. When the placenta is bigger, we can have an hyper beta hCG levels. So now this is what we've identified is the fetus at 9 weeks and 3 days. So the baby looks absolutely great. So we could have identified the nasal bone and the ductus and absolutely. But then these are the multiple venous lakes that probably draw our attention. And then we have it's a huge sort of an venous lakes and sort of an honeycomb appearance in one part of the placenta. So then we try to look around. And so we have at this intramyometrial or close to the endometrium, right? Endometrial myometrial junction. We identified this gestational sac with some fetal pole, right? And then these are the different complications that can happen to the mother. So now in the single pregnancy, so in the single pregnancy, what could happen is this, that we can have a fetus with a placenta which is having a partial mole, right? So once the partial mole would be there in the same fetus, we would have a severely restricted fetus, which is not the case. So the baby is doing good. The amniotic fluid in this sac is also absolutely fine. So meaning thereby that we are not dealing with something in which we are having the baby with a partial mole. The second case scenario becomes that probably she had conceived, or we have conceived as a twins, DADC twins. So one baby went into vanishing and then the placenta survived and then it led into partial mole, but the second baby, the fetus and the placenta are normal, right? So that is the base case scenario, meaning thereby that we have identified the gestational sac which is there at the myometrial endometrial junction, in which we could identify non-viable sort of a fetal pole also. But then what to do about the beta hCG levels, right? Okay, so that can lead to a lot of sort of an hyperemesis gravidarum, lot of vomiting, severe vomitings. We can have a preeclampsias, you know. So meaning thereby that for all these things we need to be watchful for. Since the fetus is normal and then the amniotic fluid in the gestational sac is normal, so that is very reassuring that probably we are not dealing with that situation in which you have the fetus and the same placenta with the partial mold, right? So this beta hCG needs to look around for as far as those anemias and the preeclampsias, and then the hyperemesis have. So probably all those things they can occur, and therefore we need to be watchful for all those things, right? And we need to counsel regarding the maternal symptomatology as far as I believe that the fetus is doing absolutely great. Now, how do you confirm? You confirm it by doing two things. Either we do the invasive stuff to the placenta, which is having that honeycomb appearance and vis-a-vis of the fetus. So, which I believe that probably 16 weeks would be the best time of doing it. So, in fact, we can do the we don't intend to do it. This is just a theoretical possibility that probably we can do that. The thing is this, that probably you do the amniocentesis. So since the baby is absolutely great, and therefore they would not be having any issues regarding the forearm and syndactyly and growth restriction. I believe that the baby would not be triploidy, and the placenta vis-a-vis the second placenta, which is showing those honeycomb appearance, can show you a triploidy, right? So this is how the confirmation. So probably we need to do two procedures. One is the amniocentesis, and second is a placental biopsy to that the placenta, and then that would show a normal fetal karyotype and a triploidy. So that would confirm our this case scenario, right? Okay. Thank you very much for your patience.